Hi everyone, my name is Brandon, and today I will be discussing optimizing treatment in hypertension. An overview of today's talk. So I'll start with a little background on hypertension, covering its definition and epidemiology. Next, I'll go into the fairly complex pathophysiology of hypertension. We won't do a deep dive into that, it's a little bit out of scope of this presentation, but I'll review some of the factors involved because they do relate to the drugs used for treating it. And so I think it's helpful to see some of that background pathophysiology and how it relates to the treatment. Next, I'll look at current diagnostic criteria based on some of the latest guidelines, along with treatment goals and how those should be individualized and be patient-specific, although certainly there are some general goals to follow for all patients with hypertension. Then I'll look at lifestyle modifications that can significantly impact blood pressure and have a positive impact, perhaps keep patients off medications or delay using medications. And then we'll look at the four first-line classes of medications used for treatment of hypertension, and those will include thiazide diuretics, ACE inhibitors, angiotensin II receptor blockers, or ARBs, and calcium channel blockers, or CCBs, as you'll see them abbreviated here. And then finally, I'll discuss some of the comorbid conditions and special populations and how to manage those, or if there's any preference for a specific medication or medication class in those scenarios. So a little background on hypertension. It is defined as persistently elevated blood pressure. It is a very common chronic disorder, typically seen in older adults, with about 120 million or so US adults that would be considered to have hypertension. Now, hypertension has been termed the silent killer because it's mostly asymptomatic disease, and over time this can lead to increases of risk of cardiovascular disease, so think of a MI or heart attack, stroke, or kidney disease. And so the goal here is to identify and prevent or delay some of these complications related around cardiovascular or kidney disease in patients with hypertension. A little bit about the pathophysiology. So it involves a multifactorial interaction between genetic, environmental, neural, hormonal, and renal factors. So it's fairly complex, and there's a lot of things involved. So patients can have genetic predispositions to it, although that's not the only thing that will impact someone's risk of developing hypertension. Diet, physical activity, and stress levels are some environmental factors that can significantly influence blood pressure. So high sodium intake, low potassium intake, and being overweight or obese are well-known risk factors as well. Neural factors, so the sympathetic nervous system plays a critical role in blood pressure regulation. So overactivity of the system can lead to vasoconstriction and then increased heart rate, which would contribute to hypertension. Hormonal factors such as the renin-angiotensin-aldosterone system, or RAS, is also a key hormonal pathway that regulates blood pressure. Dysregulation of this system can lead to increased blood volume and vasoconstriction, thus impacting someone's blood pressure. And finally, renal factors, so the kidneys regulate blood volume and pressure through sodium and water balance, and so impaired renal function can contribute to hypertension as well. So understanding these mechanisms is helpful for developing an effective treatment strategy. So knowing the things that are involved and how some of the drug classes that we'll talk about can interact with these systems and improve someone's blood pressure. Now, the factors I've discussed here are thought to be primary drivers of primary hypertension. However, secondary hypertension is defined as hypertension that is due to a specific cause, such as chronic kidney disease, obstructive sleep apnea, or hypothyroidism. So there's a distinct cause for someone's hypertension versus the interplay of all of these different factors, which is typically what you see, but in some instances there is a primary driver of that. Additionally, there are also certain drugs that can increase someone's blood pressure. So if a patient is hypertensive, you want to be wary about using some of these drugs with them depending on the scenario. So drugs such as NSAIDs, amphetamines or stimulants, bupropion, venlafaxine, pseudoephedrine, caffeine, energy drinks, and then certain supplements such as ephedra, immunosuppressants such as tacrolimus or cyclosporin, And then steroids such as prednisone would be some examples of drugs that can increase someone's blood pressure. How is someone diagnosed with hypertension? So according to the 2017 ACC-AHA guidelines, there are 4 different categories. So someone would be considered to have normal blood pressure if their systolic blood pressure is less than 120 and their diastolic blood pressure is less than 80. They would be considered to have elevated blood pressure if their systolic blood pressure is between 120 and 129, but their diastolic blood pressure is still less than 80. And then we get into hypertension. So stage 1 hypertension is defined as a systolic blood pressure between 130 and 139, or a diastolic blood pressure between 80 and 89. So it can be an or situation here. If their systolic or their diastolic are out of range, then that would be considered stage 1 hypertension. And then stage 2 hypertension would be defined as a systolic blood pressure greater than 140 or a diastolic blood pressure greater than 90. So accurate blood pressure measurements are critical for diagnosis, and we don't just do this as a one-off. It should be measured on 2 or more occasions to confirm the diagnosis of hypertension. A proper technique includes using a properly sized cuff, depending on how small or large the patient is, ensuring the patient is seated comfortably, they've waited and rested for about 5 minutes, and they've avoided anything that might artificially increase their blood pressure for maybe the last 30 minutes to an hour. So things like exercise or caffeine, smoking, although smoking doesn't necessarily contribute to increase in blood pressure, we want to avoid those kind of things before getting an accurate reading. And you can look at those guidelines. So the 2017 guidelines has some really good information on all the steps involved in proper blood pressure measuring technique. Next, we'll get into treatment goals. And so there's a broad treatment goal. Not all guidelines will completely agree with what a goal for patients should be, but for most patients, a more aggressive treatment goal of 130/80 is appropriate. Now, it might not be appropriate for all patients, but generally speaking, that aggressive treatment goal of less than 130/80 is what you should be aiming for, unless there's some other reason to increase that goal or be a little bit more laxed about it. So especially in patients that are high risk for cardiovascular disease or that have established cardiovascular disease, we want to use that aggressive treatment goal. However, a higher goal, such as something like 135/85 or 140/90, might be appropriate for some patients. So if a patient has a history of falls, older patients, non-ambulatory patients, or those with a significant medication burden, could be some example scenarios where you might have a little bit more of a relaxed goal for treatment. And it's just always important to remember that that goal should be patient-specific and tailored to a number of things. So their age, their preferences, risk of side effects, and how they're doing on that treatment. Next, let's look at some lifestyle modifications that can improve a patient's blood pressure. So ideally, if a patient is not at high risk or they don't have stage 2 hypertension, and by high risk, I mean high risk of cardiovascular or renal disease, or they're not at stage 2, it might be appropriate just to start with some lifestyle modifications for a little bit and see how that goes. So one of the biggest things that can reduce a patient's blood pressure is following to the DASH diet. And so this generally is going to involve reduced sodium intake, so less than 2,000 milligrams a day. If less than that, that's even better. And increased potassium intake, so somewhere between 3,500 and 5,000 milligrams a day of potassium. And emphasizing things such as whole grains, vegetables, fiber, and protein, and trying to avoid those things, fast food, fatty foods, things like that, that we just know aren't really all that good for us. Next, exercise, so at least 150 minutes a week. If someone can't do that, still it's better to get some exercise in than no exercise, so increasing activity and exercise is a good way to decrease someone's blood pressure. Weight loss, if someone is overweight or obese, and they don't have to get all the way down to an ideal body weight, but the more weight loss someone is able to obtain, the more impact that's going to have in a positive manner on their blood pressure. And reducing alcohol consumption. So for men, 2 drinks a day. For women, 1 drink a day. And then again, less than that is even better. So reducing alcohol consumption can help with management of hypertension. And then the other thing to mention is just smoking cessation. So like I mentioned a little earlier, it doesn't necessarily increase someone's blood pressure, but we know with hypertension, some of the morbidity and mortality are related to cardiovascular disease, which smoking obviously contributes to. And so it's just taking out that additional risk factor for cardiovascular disease and smoking cessation. So that's another important point for patients with hypertension. And then I'd also mention stress management. So techniques such as mindfulness, meditation, yoga, deep breathing, and things like that to help a patient reduce their stress so they're not smoking or drinking or eating or having a bad diet. So identifying stressors and coming up with stress management can be an important lifestyle modification as well. So there's the stress itself and then some of the things that stress could lead to. Now, as I've mentioned, there are 4 main first-line treatments for hypertension: ACE inhibitors, ARBs, calcium channel blockers, and thiazide diuretics. So in the next 4 slides, I'm going to go into these in a little bit more detail. So ACE inhibitors, some examples here that we see are lisinopril, benazepril, ramipril, and their mechanism of action involves blocking the conversion of angiotensin 1 to angiotensin 2. And this leads to vasodilation and reduced aldosterone secretion. And so if you think of this, angiotensin 2 is going to lead to vasoconstriction, and we're just sort of reducing that effect. Some of the common side effects patients see on ACE inhibitors would include things like a dry, persistent cough, hyperkalemia or increased potassium levels, and although rarely, this can be really serious, angioedema. ACE inhibitors also block bradykinin degradation, which is thought to contribute to that dry, persistent cough that I mentioned. So that dry cough is quite common in patients taking ACE inhibitors, and if they're unable to tolerate that, maybe switching to something like an ARB would be a good idea. So when starting ACE inhibitors, it's important to monitor for acute hypotension, and it might be prudent to start patients at lower doses that you think might be prone to acute hypotension, so older patients or those on other drugs that might be lowering their blood pressure. And then also monitor for increased potassium levels and a decrease in GFR. So you might expect a small to moderate increase due to the mechanism of action of ACE inhibitors in the GFR, and that's okay. But if you start to notice anything more substantial than a moderate decrease in the renal function, then maybe it's time to think about an alternate drug. Now, like I mentioned, angioedema is a very serious but also very rare side effect. And so patients with a history of angioedema should not be taking ACE inhibitors, but they could trial an ARB potentially, although you would use some careful monitoring. So it might be better to start patients with a history of angioedema either on a calcium channel blocker or a thiazide diuretic. And if those don't work, maybe go to an ARB and try that. And ACE inhibitors are also contraindicated in pregnant patients. Next, we'll look at angiotensin 2 receptor blockers, or ARBs. So they block the effects of angiotensin 2 by preventing it from binding to the AT1 receptor, which leads to vasodilation. Now, angiotensin 2 is also created by another pathway different from ACE, where the ACE inhibitors work. And so ARBs not only block the angiotensin 2 from the ACE inhibitor pathway, but also this alternate pathway as well. So they can be pretty effective drugs. Some of the common side effects include hyperkalemia, dizziness, and hypotension. And since ARBs do not impact bradykinin degradation, you don't really see that dry cough. And so that's why I mentioned earlier, if that's a persistent issue for a patient, maybe switching that's on an ACE inhibitor, maybe switching them from that ACE inhibitor to an ARB could be helpful in that scenario and help maintain compliance. ARBs are generally fairly well tolerated though, and they do have a minimal side effect profile. And so this could be a good choice of drugs if a patient already has a high medication burden or you're worried about side effects or compliance. And some of the examples we see here for ARBs would be things like losartan, irbesartan, olmesartan, or valsartan. And just like ACE inhibitors, ARBs are contraindicated in pregnant patients. Next, we'll look at calcium channel blockers. And the examples I have here would be amlodipine, felodipine, and nifedipine. These drugs inhibit calcium ions from entering vascular smooth muscle and cardiac cells, causing peripheral vasodilation and then reducing peripheral vascular resistance, which can be one of the main drivers of hypertension. Typical side effects includes things like edema, and that edema can be dose dependent. So the higher dose someone's on, the more likely you are to see edema, especially around the feet or ankles. So also I would mention diltiazem and verapamil are some other calcium channel blockers that have antihypertensive effects. However, they can also cause some cardiac abnormalities, and they might not be the best compared to the dihydropyridines, such as amlodipine, felodipine, or nifedipine. In addition, verapamil is also known to cause constipation, which can be severe in some patients, and so generally diltiazem and verapamil, not necessarily wrong choices, but they would not be my go-tos for calcium channel blockers for hypertension treatment. I would look at the dihydropyridines first, so things like amlodipine, which is a very commonly used drug, or felodipine, or a long-acting nifedipine formulation. And so it's the long-acting nifedipine that should be used, not a short-acting formulation for hypertension treatment. Next, let's look at thiazide diuretics. So we have two examples here, hydrochlorothiazide, or HCTZ, and chlorthalidone. And so these diuretics inhibit sodium reabsorption in the distal convoluted tubules, and that leads to increased diuresis and a reduction in volume. And that's how their mechanism works to decrease blood pressure. Some common side effects include hypokalemia, hypomagnesemia, and hypercalcemia. Generally speaking, chlorothalidone is preferred over HCTZ, but HCT is fine and is still very commonly used. Chlorthalidone is just more potent and longer acting than HCTZ. And as I mentioned with some of those side effects, electrolyte imbalance is the main concern for patients on diuretics. So watch for, in addition to the hypokalemia, hypomagnesemia, and hypercalcemia, watch for hyperuricemia, and that can be especially important in patients with a history of gout or elevated uric acid levels. Also watch for hyperglycemia, especially in diabetic patients, and dyslipidemia. So patients that are already at increased risk for cardiovascular disease, those could be some things you might want to monitor a little bit more closely if they're on a thiazide diuretic. And it's also important to note if a patient starts to have reduced renal function, so GFR less than 30, or if edema is a major concern, you might want to consider a loop diuretic instead of the thiazide diuretics. Next is a drug dosing table. So all the drugs I've reviewed here, I've included their typical dosing for hypertension, some dose adjustments to think about, some major safety points, and then a clinical pearl for each of these. Now, I'm not going to read through this. I'll let you do that when you look at the slides, but just for your reference, here's a drug dosing table for the drugs that I've mentioned. Next, let's look at comorbid conditions and special populations in regards to patients with hypertension. So heart failure with reduced ejection fraction. The first thing to look at here would be ACE inhibitors, and then maybe ARBs, beta blockers, or MRAs such as spironolactone or eplerenone in patients with heart failure with reduced ejection fraction. If the patient has heart failure with preserved ejection fraction, diuretics are maybe a good starting choice here, but really any of the first-line agents could be good here. So maybe an ACE inhibitor, an ARB, or consider an MRA as well. In patients with stable ischemic heart disease, beta blockers can be pretty big here, and then an ACE inhibitor or an ARB as an add-on, and that's going to reduce the risk of a recurrent MI and improve survival for patients with stable ischemic heart disease. In patients with diabetes, we want to think of an ACE inhibitor or an ARB, especially if they have proteinuria, but just starting a patient with an ACE inhibitor or an ARB if they're diabetic could be a good strategy here. And this is going to protect their renal function and reduce their cardiovascular risk, which is already elevated due to hypertension and diabetes. In patients with chronic kidney disease, ACE inhibitors or an ARB are the preferred agents, and we're going to do that to slow the progression of renal disease by reducing glomerular pressure and proteinuria. For secondary stroke prevention, thiazide diuretics are a good choice, and then ACE inhibitors or an ARB as an add-on would be a good strategy here. In pregnant patients, so remember ACE inhibitors are contraindicated, ARBs, the MRAs, so spironolactone, eplerenone, those are contraindicated. But some good options in pregnant patients with hypertension would be drugs like methyldopa, labetalol, or that long-acting nifedipine. And then finally, Black patients. So Black patients with hypertension tend to respond better to thiazide diuretics and calcium channel blockers compared to ACE inhibitors and ARBs. So in the Black population, starting off with a thiazide diuretic or a calcium channel blocker might be a good choice there. Okay, to summarize today's talk, so we looked at hypertension and how it's a common chronic disease in the US with a complex and multifactorial etiology, with the long-term negative effects on the cardiovascular and renal system. So all of our treatments are really geared towards preventing those things. Diagnosis involves 2 or more occasions of elevated blood pressure, and so remember some of those tips for getting an accurate blood pressure reading. Let the patient relax for about 5 minutes or so on 2 or more separate occasions, and avoiding some of those things that might increase their blood pressure before measuring it. So things like exercise or coffee or some of their medications. So if a patient's on a stimulant, maybe waiting till after you get their blood pressure before taking their dose for the day. And then treatment generally involves lifestyle changes, so review that, especially the DASH diet and some of these other lifestyle changes that can impact blood pressure. And then medications, so the 4 medication classes: ACE inhibitors, ARBs, calcium channel blockers, and thiazide diuretics. It's important to note that most patients will eventually need more than 1 medication, so you might have to use 2 of these different medication classes, and it's best to avoid using both an ACE inhibitor and an ARB, but you could mix in an ACE inhibitor and an ARB with either a calcium channel blocker or a thiazide diuretic. That would be a much better strategy than using ACE inhibitors and ARBs, since they're kind of essentially going at the same mechanism, although albeit a little bit differently. And then we reviewed some of the comorbid conditions in patients with hypertension and some specific patient groups that can benefit from specific agents. And that will be the end of today's talk. So here's some references if you want to read more about managing hypertension. Thank you for sitting through this talk. And if you want to learn more about this and other topics, be sure to visit Pygene Academy for more information.